Hello, how are you? Today I want to present to you a clinical case. Today I want to talk about cases of cardiac arrhythmias that develop after surgery to treat stenosis of the heart aortic valve. This happened while I was working in a hospital in Scandinavia as a senior and consultant on-call doctor. There was a patient who returned to the hospital after undergoing TAVI, transcatheter aortic valve implantation. AV block was observed on the patient's ECG, and so he was admitted with telemetry monitoring. I was not directly involved in the case or treatment of that patient, his case but his case was discussed at the medical meeting one morning. And soon later, about 2 days later, I was at the emergency room as a senior doctor at a medical clinic, and I received a call from the junior shift who wanted to talk to me about a patient. A man who arrived at the emergency room feeling like he was fainting, but had not fainted. He informed a colleague who was on junior shift that he had been feeling this near fading sensation for the past 5 days. This sensation was most noticeable when he was doing something, usually a mild to moderate activity. He had undergone TAVI 11 days before the onset of the feeling of fading. He had not fainted or passed out on any occasion. When we looked at the ECG, it wasn't clear to us, but it could be interpreted as atrial fibrillation or flutter. The machine interpreted it that way, but I was able to find a wave that fit like a P wave, and then maybe an extra pulse. But also it could be interpreted as bigeminy or AB block 2 of the morbid 2 type. The last was probably the correct interpretation. Unfortunately, I don't have a photo of that electrocardiogram, but now I leave some picture here and then I ask you to use your imagination. The last one was probably the correct interpretation. We monitored him all the time with telemetry, and we did several electrocardiograms in the emergency room and then in the coronary unit. Approximately 1.5 hours after his arrival, still at the emergency room, the electrocardiogram was clear for AB block 3, but with a rate of 135 bytes per minute. I personally have not seen an AB block that goes so quickly before. So he was moved to the coronary unit, and I ordered that he have isoprenoline ready to administrate when necessary, and the transient transcutaneous pacemaker primed and attached. We glue it anterior-posteriorly. I don't have much experience with cases like this, so fortunately, there are more experienced colleagues to call and consult. I called the cardiology emergency room at another hospital that works together with the one I was at. The colleague thought it was a strange rhythm, but agreed with the diagnosis, AB block type 3. The colleague was able to see images of the patient's ECGs at the other hospital. By then, the rate had already dropped to 35, sometimes less, The lowest rate we recorded was 32 bytes per minute, but it only stayed at that rate for half a minute or so, maximum 1 minute, and then it went up, although not so much. It rose to 70 or maximum 80 bytes per minute, but the patient did not develop symptoms. He felt the same all the time. He said he felt weak lying down, a little tired, but it was not worse when his pulse went down. And I didn't want to start administering isoprenoline because he did not have a low pulse during enough time or symptoms. I want to tell you that this patient had previously had in previous 2 ECG, 2 times at least, paroxysmal atrial fibrillation or flutter, which had been recorded about a few years ago, at least what I remember. But curiously, he did not have any medication like DUAC or warfarin and nothing for frequency either. He only used acetylsalicylic acid, Spiolto-Respimax, which is olodaterol, and tiotropium, the nicotine patches. He had COPD or chronic obstructive pulmonary disease as a chronic diagnosis and was a smoker, but he was trying to quit smoking and used nicotine patches. It is also a little more concerning when you have a patient with AV block who isn't using any medication that can lower the heart rate, like beta blockers, for example. He didn't have them. This can be discussed without giving specific information about the patient. Therefore, I will not say his name or when this happened or his exact age, but I can say that he was between 60 and 70 years old. These previous ECGs, these records, were not from the hospital. I want to clarify that the system in Scandinavia saves all records, some studies, or measurements in a database. So if someone in the health center takes an ECG from the patient and chooses to save it in the system, it will be there, which is good. It's good to have ECG for compare after or previous blood test or previous blood pressures measurements. But what is not very good is that 2 ECGs have been taken previously and no one has reflected on the rhythm of the ECG. An atrial fibrillation that who knows when it began appears paroxysmally, but that could have caused an embolism, a stroke, by not having prophylactic treatment with anticoagulants. Check out the videos I made about the stroke for more information on it. Well, we agreed with the cardiologist that the patient should be transferred to the hospital where the cardiologist was the same night to have a pacemaker inserted. So he was moved to the hospital, and as far as I know, everything turned out well for this patient. I will comment that I spoke with the patient at the coronary unit and asked him about alcohol consumption. He said that he drinks a little alcohol on the weekends. The day the symptoms started was actually a Monday, curiously. In general, alcohol tends to trigger arrhythmias in sensitive patients, but TAVI itself also does that. So it was a bad combination of arrhythmia triggers. But how common it is with AV block after TAVI or other arrhythmias? It was interesting for me to check it out, see for more information, because we had two patients in less than a week with the same complication after TAVI. I can recommend consulting the following link. But how often do you see complications? I didn't find specific data, but if you see the following link, here you can read after TAVI the risk of AV block clearly increases, but cardiac arrest is a rare complication because these patients are monitored for several days after the intervention and, if necessary, a pacemaker is implanted. Well, what happened with this patient that I'm telling you about, and also with the other one that I knew less about but that was discussed in the medical meeting, they both get pacemakers. In parentheses, I would like to mention that those patients with AV free block usually receive a dual chamber system pacemaker or DDD or DDDR or dual chamber right. By having two electrodes, one in the right atrium and one in the right ventricle, each one can detect intrinsic electrical activity to determine the need for stimulation in each chamber, right atrium and ventricle. This is when the patient is in sinus rhythm, when AV block and AV synchrony is desired during pacing. In case of intermittent AV block, DDD with AVM, AV delayed management is recommended. Activation of the frequency response function in chronotropic insufficiency, VVI or VVIR, can also be used in persistent atrial fibrillation or other atrial arrhythmia with a slow ventricular rate, problems with bradycardia, or chronotropic failure. Only ventricular pacing because the atria fibrillate. If necessary, the rate response function is activated for better rate variability. Here we can see international data. In recent years, transcatheter aortic valve implantation has become an alternative procedure in patients with severe aortic stenosis and high risk for surgical aortic replacement. Due to the anatomical correlation between the structures of the aortic valve and the conduction system of the heart, one of the most common complications after TAVI are alterations of the conduction system that include bundle branch block, complete heart block, and the need of implantation of a permanent pacemaker. Although these disorders are not usually fatal, they can have a significant impact on patients' conditions and long-term survival. Several risk factors for conduction disturbances have been identified, including age, cardiac anatomy, periprocedural factors, type of valve implanted, persistent anomalies, and comorbidities. As these techniques become more familiar to clinicians, patients should be carefully screened for risk factors, development of conduction disturbances after TAVI to provide effective prevention and appropriate treatment. A little further down, it says, transcatheter aortic valve implantation is an expanding catheter-based technology that allows the implantation of a prosthetic valve without the need for open-heart surgery for the treatment of severe aortic stenosis. This technique was developed more than a decade ago, this article is from 2018, to minimize surgical risk and high-risk patients with severe symptomatic aortic stenosis, such as the elderly or those with contraindications to open AVR or aortic valve replacement. Given the anatomic proximity of the AV node to the aortic annulus, conduction disturbances caused by calcification or mechanical trauma can lead to AV block with a consequent need for a pacemaker. In the literature, this is described in 6% of cases after surgical replacement of the aortic valve, but varies after TAVI between 5.7% and 42.5%, while new left bundle branch block occurs in up to 50 to 70%. Then I found an article from a Swedish medical journal. Pacemaker after TAVI was not associated with increased mortality. And I mentioned this article here because it provides more statistic, as it says, treatment of patients with advanced aortic stenosis by transcatheter aortic valve implantation TAVI has increased significantly over the last decade. TAVI allows treatment even in patients who are not considered operable and is increasingly used in younger patients and at low operative risk. The most common complication after TAVI is the need for a permanent pacemaker, which occurs in about 10 to 20% of patients, compared to about 3 to 5% after surgical aortic valve replacement. The prognosis in patients who received a pacemaker after TAVI is not completely known. Therefore, I think it's important to know and keep this in mind that after TAVI, about 10 to 20% of patients might need pacemakers, and the most common arrhythmia that leads to this is AV block, the type 2, Morbis 2, or 3. And here I leave you this. I would like to read your comments if you have or have experience with this, if you can add any important information that I do not mention here as a doctor, nurse, or physiotherapist, or a patient. And well, thank you for your attention and be very, very well.